So this topic is going to be clinical examination of lumbar spine. I'm not going to repeat whatever Mrinal has said about cervical spine. A lot of it is relevant for lumbar spine also. So I'm a senior physician in rehabilitation medicine and pain medicine. I also has an admin role. I'm trained in CMC Vellore and spent a few years in CMC and then in Australia for the rest of the time. Next slide. Okay, I can look at that. Yeah, thank you. Okay, I have a question here. How confident are you in your lumbar spine clinical examination? What are your thoughts? How confident are you? Very good, medium, poor, none. Okay, that's for you to reflect on. And you can look at the end whether your skill has improved. Okay, what's the objective here? So we talk about clinical examination, we talk about the history, we look at the examination techniques a little bit, and we look at the interpreting the findings, looking at the whole picture, not isolate findings. Now, why do we have to do a clinical examination? The reason I'm asking this question is that I see a number of people who has actually seen 5 or 6 doctors before, and one thing they commonly tell me that nobody has actually examined me. This is real. So what do we do as a PMR physician? What is our unique selling proposition? If you are from a management world, there is 2 things which is important. One is what is your unique selling proposition. Second is that what is the value you are adding. So why do people have to come to you? What will you provide to them which other people don't provide? Otherwise, why should they come? They can go to, there will be 1,000 other doctors. Oh, many thousands of doctors. So what difference will you provide to them? What's the value you provide? That's very important. I think you need to reflect on it. If you want to be a good PMR doctor, you need to actually reflect on that, and you have to actually have a value, or you have to have unique selling stuff. That's how in people market things. Anyway, so why do we actually do a clinical examination? It provides information. It actually develops a trust and rapport with the patient. It's part of a patient-centered care. And as I mentioned, I believe in this whole person approach. That's one of the reasons I actually took rehab medicine as my career. You have to actually understand the person as a whole, not their pain alone, not their simple things. Understand that person as a whole. And definitely a clinical examination reduces the diagnostic error. The reason I'm saying is that as I mentioned, I said most of the patients I see, at least I've seen at the 5 other doctors, and all of them would have had an MRI. And you look at an MRI report, for example, look at an MRI lumbar spine report, 90% of the report will have a lot of things written there. It's got foraminal stenosis, it's got central canal stenosis, it's got facet degeneration. But whether those things are important, I don't know. As you all know, a lot of literature actually suggests that a lot of those findings doesn't have much meaning. So it actually gives you a lot, clinical examination gives you that information which actually reduces your diagnostic errors. As Mrinal mentioned, when you actually talk about a lumbar spine, you need to be careful about certain things. Malignancy, either a primary malignancy or a secondary malignancy, Kochiyil syndrome. This is a rare thing. I mean, the chance of somebody having a Kochiyil syndrome is very, very rare, but it's real. And if you can actually identify it appropriately, you can actually have treatment. Probably the patient never will have a bowel or bladder dysfunction. Otherwise, even after with best treatment, bowel and bladder dysfunction is very, very common. Infections, Mrinal mentioned about it. We have to be worried about those infections. Sometimes, especially in the lumbar spine, infections are like caused by organisms which are not that virulent. So the signs of infection or general signs of infection will be very little. Inflammatory arthritis, real again, you have to take an appropriate history to identify. Fractures in lumbar spine, mainly an osteoporotic fractures. And there are a number of mimics. I'm always interested in these mimics. Abdominal aortic aneurysm, very common mimic. Pancreatic pain, I have seen n number of people who present with lumbar spine pain, they have a pancreatic lesion. Pelvic inflammatory disease, I hope Ravi will talk more about it. Pain from hip, that's very common. A lot of lumbar spine pain is actually not from spine, it's actually from the hip. Hip can cause pain because of the biomechanical changes in walking, as well as it can directly cause pain. Retroperitoneal hematoma, especially the people are on anticoagulation. Some of the retroperitoneal hematoma present as lumbar pain, not as leg pain. So you just have to be careful with all of those things. Where do we start? Take a proper history. I spend more time on taking history than actually examination, because history gives you more information and it actually helps you to focus your examination to the structures you wanted to examine properly. So pain, Mrinal mentioned about it. You always wanted to know about the different type of pain. Is it neuropathic pain? Is it nociceptive pain? Whether it's a radicular pain with radiculopathy, pseudo-radicular pain, you name it. I'm interested in knowing functional limitation. Before I go on to anything else, I'll ask the patient, what is the limitation? Because I'm a PMR doctor. I'm a doctor of function. That's what American Association of Physical Medicine and Rehab says. So I'm interested in knowing what their functional limitation. I mean, we all have some back pain. I mean, either 90% of people get up in the morning has got some back pain. It's very common, and it's commoner as we age. All of them doesn't cause any functional limitation. So I really want to know what their functional limitations are. I'm interested in knowing whether they have any claudication pain. You probably know about two types of claudication. You talk about neurogenic claudication, and you also know about vascular claudication. So a history will tell you whether they really have a claudication. I want to know about their sleep. I want to know about how they feel. I spend time in understanding whether they have any symptoms of a sinister pathology, which Mrinal has mentioned very detailed about the symptoms of malignancy, symptoms of infection, and all those things. I'm always interested in knowing whether they have more pain when they are lying down. If somebody says that they have more lumbar pain when they are lying down, I'm really worried about a retroperitoneal problem. And I really wanted to make sure that they don't have a retroperitoneal problem. Because most of other garden variety lumbar pain is actually worse when you stand and walk, not lying down. They're thinking and understanding about causation. What is causing the pain? Because that's your common sort of medium of discussing with the patient. And Mrinal mentioned about catastrophization. They actually think about worse about their pain. They think that they will not be able to walk in 3 months' time, 6 months' time. Then you're actually talking about their emotional aspect. They're talking about psychological aspects. I'm interested in knowing their previous treatment. I don't believe more will do better. There's no point in doing the same thing again and again. If people are not getting better with a treatment, we actually we have to direct it in some other way. So for that, you need to know what they have already done. Now, what are the structures you are interested in lumbar spine region? What are the structures? What are the structures interest you? Somebody coming with a pain in the lumbar region, little bit of pain in the leg. What are the structures which interest you? Because that's going to determine what you're going to do in examination. Can you tell me, where do we start? I think that's somewhere there. This is a problem with backbenchers. You will get more questions. So what are the structures interest you? One of those back tables? Anybody? It's easy. What are the structures in lumbar spine or lumbar region interest you? No answers? We can't go home, or we can't finish today's session if you don't answer this. Does the vertebrae interest you? The disc interest you? Ligaments? Paraspinal muscle, there's a number of paraspinal muscle, multifidus, erector spinae group, transverso spinalis group of muscle. There's a lot of literature on multifidus and lumbar pain. In fact, people actually doing multifidus dimensions, measuring the multifidus, looking at the atrophy of multifidus. So there's a lot of literature on paraspinal muscles and lumbar pain. What else? And there is also there is actually a stimulator which you can actually insert into the spine, which actually stimulate the multifidus muscles, which has got some evidence for reducing lumbar pain. There's a lot of fascia around. And there are muscles like glutei, there are muscles like psoas, all those things interest you. So your examination actually depends on what history you get, your examination should look at some of those structures. And I always ask the patient, do you have pain when you're bending forward, or do you have more pain when you bend backwards or extend? What does that tell you when you have more pain when you bend forward? It's probably a disc. When you bend backwards, especially an elderly, it's more like a facet. Oh, Mrinal said you can't say facet. Anyway, I'll say facet. Okay, right. So these are the structures which interest you. So you start with inspection. I always look at inspection, palpation. I'm an old style physician, so look at inspection, palpation, special tests. So main thing you look at is whether there is any thoracic kyphosis, lumbar lordosis. You're interested in more kyphosis, more lordosis, less kyphosis, less lordosis. Why is lumbar lordosis important? So sometimes you see hyperlordosis, sometimes you see less lordosis. So when you have hyperlordosis, what has happened to? What does that tell you? What are the causes of hyperlordosis? More bend of lumbar spine. I mean, it tells you a lot of things. It tells you that whether you have weaker hamstrings, whether you have tight hip flexors, whether your pelvis is tilted anteriorly. That's one of the things which happens. So, and when you have less lordosis, what happens? Usually associated with hamstring tightness. And also when you have less lordosis, that's the position where neural foramen is at the shortest, smallest diameter. So a lot of people when you have less lordosis, complains of some radicular type of pain. And then you look at whether there is any scoliosis. So different type of scoliosis, C scoliosis, S scoliosis, all those things as a part of your inspection. Then you can do a palpation. You start with midline, look at the spinous processes in the spinous region, then move on to paraspinal region. You probably get some tenderness in the paraspinal region, probably give some information about the facets. You can palpate the SI joint region. I always look at palpating along the iliac crest because a lot of pain generators around that iliac crest, especially the posterior part of the iliac crest. Then I actually look at an active movement. Gives you some idea about what the patient can move. And also you can use that as a guidance in terms of what improvement patient makes. So active spinal flexion, extension, and lateral flexion. Then you can look at some special tests. I tend to do sitting SLR. Some people call that a tripod test, where we actually, when you make the patient sit and straighten the leg, you actually, the patient, if they have a neural tension, the patient will go back and try to support with their arms. So it's like a tripod sort of thing. You can look at a straight. That got, as Mrinal mentioned, these tests all have variable sensitivity and specificity. So if you can actually use more than one test, that actually provide a little bit better sensitivity and specificity. Straight leg raising test, especially for L5 and S1 root, especially if it is positive between that 30 and 60 degree angle, and also that pain increases with ankle dorsiflexion and reduces with knee flexion. That actually gives you a little bit more sensitivity to the finding. They say that if you really wanted a specificity, you actually need to do cross straight leg raising. So you raise the normal leg, and that causes pain in the affected side. For that to be positive, you probably require quite a big disc. Then you can actually do a femoral stretch test. You can look at this. You can Google it, and there's enough videos about this. It will actually look at the L2 and L3 roots. I tend to do a facet loading. It's again one of the tests which probably won't tell you a lot, but if it is positive, then it might direct you towards the facet joint. So basically, you can actually extend, slightly rotate, and then sort of compress those facet joints to see whether there is pain. You can do a flexion, abduction, extend, rotation, or otherwise called figure of 4 test, because at the end, it's like a 4. Again, it tells you something about facet joint. It probably also tells you about hip joint, tells you about the SI joint. It's a test which any of this is your pain generator. That test could be positive. You can do a modified Schauber's test. The Schauber's test has been modified by almost everybody. This is modified Schauber's on top of it. But probably modified Schauber's has got slightly better sensitivity and specificity than any other test. If you really look at an inflammatory arthritis, is probably one of the tests you should be doing. You can do a neurological examination. You have myotomes, L3, L4, L5, and S1 myotomes. You can also do a deep reflexes of knee and ankle. Traditionally, knee jerk has been L3, 4, but there is a lot of articles you can see actually diminished knee reflex with L5 root lesions. So these are not 100%, but it gives you a direction. If you have absent reflexes on one side and normal reflex on the other side, especially knee, will actually tell you that there is some abnormality. Angle reflex, if bilaterally absent in an elderly person, may not tell you anything, because a lot of people at the elderly age, angle reflex is absent. But in a young person, unilateral angle reflex, absence of angle reflex, has to be a S1 lesion unless otherwise proved. Then you can look at the sensory. There's a problem with sensory assessment, though we actually bang on to the sensory assessment. A lot of people I see after a few months of a disc prolapse, like classical L4 radiculopathy, but if you look at their sensation, it's actually beyond L4 dermatome you can see. That's because, the way neural wirings are, if you have pain for a period of time, there is an ample sensitization happening in the spinal cord and the brain. So actually your pain area is lot larger than the initial dermatome. So a lot of time if you have an L4 or L5 lesion, you can actually get 1 or 2 other dermatomes also involved. So once it's acute disc prolapse, yes, they are quite useful, but as it goes, after a couple of months, they are probably less useful in actually determining one particular level. So I always look at L3, 4, and L5, L3, 4, L5, S1, and S3 to S5. There's a lot of discussion about spinal cord injury and L3 to L5, so that's also important. Although I'm interested in examining the other areas, as I mentioned, hip, abdomen for in sort of abdominal aortic aneurysm, especially in an elderly person. Inguinal hernias cause a lot of pain in the leg and the groin. Always interested in looking at the distal arterial pulses. It actually will also tell you whether there is a vascular claudication, and sometimes you have the abdominal infrarenal aortic stenosis, which causes back pain, lower leg pain, and also weakness. Those very rare conditions. I have actually seen 3 of them, which has actually been missed by many other people. So it is actually, it always need to be in your mind. There is something like an infrarenal aortic stenosis, though it's rare. As I mentioned, I'm a rehab doctor, so I always look at their functional assessment, what they can do, what they cannot do. I'll make them walk, I'll make them squat if possible. I'll ask them to walk on their heels, walk on their toes. Walk on their heels will tell you their L5 function. Walk on their toes will tell me about their S1 function. Once I have all these things, we can have all these images. You can have an X-ray, you can have a CT scan, you can have an MRI. But if you can actually do a clinical examination and tell what you're thinking, what your differential diagnosis is, and the radiologist can actually give you a better report. Otherwise, the report will be like a garden variety report. It tells you a lot of things. Does it make a sense or not? I don't know. So if a proper examination, you can have a diagnosis and differential diagnosis, then radiologists can give you a good report. Then you get a lot of these MRI report. They write a lot of things, and this is something which you really need to know. I know most of you people would have already known this. It's about the vertebrae and the nerves. So in lumbar region, the nerve root goes below the vertebrae, and so if you have got a central or paracentral disc, usually that affect the nerve root one below. If you got a far lateral disc, it affect the nerve root on the same side. That's because that nerve root is actually almost trying to exit the foramen. And the other diagram is actually comes from the MRI. So you see some of the MRI report talking about subarticular zone, facet zone, and extraforaminal zone, where the nerve root is compressed. So if you got subarticular root, it's usually a central or a paracentral disc. Facet zone is usually a disc which is actually far lateral. And you see a lot of time, I get a lot of patients who actually has a disc in contact with the nerve root in extraforaminal zone. It's one of the very difficult thing to treat, because you probably don't have an injection which will actually reach there, and surgeons are usually not very interested in treating anything extraforaminal. So that's a short review of examination of lumbar spine. I've given you some basic information. I wanted you to reflect on it. I wanted you to look at how develop your own examination technique, and there are enough and more videos available for any of the special examination if you wanted to. And so if you can take your phone and give me some feedback about this talk, I'll be very grateful. Thank you.